Good afternoon. Guess what time it is? It is 4 o'clock in the mountains, which means 6 o'clock on the East Coast. And there is only one place that you need to be, and that is right here. Fertility with Fink and Friends. I am Fink, and you are friends. And it is Tuesday, and we are back together again after a week of being off. I was on vacation, and I'm sure you can tell from my tan. It's funny because I came back here, and one of the people working here, they said, "I thought you were in Florida. Where's your tan?" And I'm like, "You're looking at it, you know. Thanks a lot." Made me feel a little self-conscious. Yes, I am the palest person east of the state of California. Actually, east of the California coastline. Put it that way. Yeah, and I embody it, and it is who I am. I am pale, but it sure is good to be back with you. I got to tell you, I really missed everybody. I missed seeing all these names and kind of spending the special time that we have together every Tuesday afternoon or Tuesday evening, depending on where you are. So it sure is good to be back. So let's see. Lobster versus Tan Club, says Mrs. Vince. Yeah, thank you very much. Hey to Jenny, a special hello to my number one on this one right here, which is my Instagram, and that is Angela in Minnesota. Thank you so much for being here today. Let's see who else we've got. We've got Crystal. Thank you, Chop. I always have a hard time saying your name there, but thank you for the welcome back. I appreciate that. Hi to Shine. Oh my, Glenda. Nice to see you, Ariel. Good to have you here as well. A special wave for you. Just Fay Music, thank you for being here. My dear friend Sydney from our embryology lab is here. One day, maybe, Sydney, I should have you on here to talk about some embryology things. That would be pretty neat. Hello to Zaneta in Miami and Maggie Cox. Thanks for being here. Who we got over there on the other one here? So this is CNY's Instagram right here, and it looks like what do we got? Abby Kadabi said, got my positive pregnancy test. I am so happy to hear that. That is wonderful. Great news. Rosa, you were number one over here on CNY. So thank you for being the first one to join Fink and Friends. West Coast Lindsay, Shay Marie, Shida, and thank you for being here. Nice to see you as always. Hello to Jordy and Kay and Kaylan and Five Money Talks. Kim, good to see you. Miss B. Hookie. Marielle, AZ Sunshine, thanks for my amazing transfer, you say. Well, thank you for sending that amazing feedback. We, gosh, would love to hear that stuff. Let's see. Hi, Ariel, Christy. Was actually Kristen Evelyn, it looks like that says. Okay, Rosa asked, and Rosa, you get first question here since you were the first one to join. Let's see if I can read it a little easier now. How often do you see endometriosis, stage 3 or 4, respond to Orilissa for an FET without excision surgery? I have no pain with an endometrioma. Okay, so you raise an important question, and that is, well, what is the purpose for using Orilissa as a medication when you have endometriosis? Is it to cure your endometriosis? The answer is no. No, what we know is that with endometriosis, you may be expressing an inflammatory marker in the uterine lining in the endometrium that's called BCL6. BCL, Bravo Charlie Lima 6. And BCL6 tells us that when it is positive, that if you, let's say, had a euploid embryo would give you about a 65% probability of a pregnancy. But if you're expressing the BCL6, then it means that 65% probability will drop down to less than, really on the order of about 10 to 12%. So that's a pretty big number. So why are we using Orilissa? We're using Orilissa not to try to cure endometriosis, but rather just to shut down that inflammatory marker that's happening in the endometrium. And the data shows us 60 days is really all you need. That 60 days does the job. So that to me is a good thing. Now, will we see any effect there on the endometrioma that you have in the ovary? And the answer is probably no. It probably will not change anything with the endometriosis that's collected in the ovary. But the whole point is to turn down the inflammation that's happening in the endometrium, specifically that BCL6 marker. So that's why we're doing that. What do we got? Best graded blastocyst to transfer. Usually what happens, so embryo grading, and you've probably heard me talk about this before. We don't get all that tied up really in embryo grading, and I don't recommend that you do either. And why does it seem to make such a big difference to people? And I think the answer to that, it lies in human psychology. We've all been to high school, presumably, or even if you didn't go through high school, you've been in some classroom, someplace where you had to turn in your homework and your assignments, and you got graded, right? You'd have to take your test, and then you'd get a grade. And what kind of grade you got in that test told your parents, presumably, maybe it told you where you were relative to all the other people in the class. So if you got an A, then that meant, oh, you have been studying and you did better than most of the people are in your class there, and that's pretty awesome. Okay, so you did great. If you got a D, well, then, you probably weren't as good as you thought you were, and everybody else was probably most people were doing better than you were, and you also probably got in trouble from your parents. Well, if you got a C, then you're probably right in the middle. So we're all used to getting graded, and these grades somehow, everything from SATs to your if you went to professional school, your grades and all these different things. Grades put you in some line, in some order with everybody else. And so that's what we're thinking of when we're thinking of embryo grading, that if you have a better graded embryo, a good grade, that must be a good thing. Maybe you have the valedictorian there, right? And but that's really not the way it works. When they came up with embryo grading, they did it because they were trying to see, well, is there a way that we could look at an embryo and determine whether it was euploid or aneuploid? So like doing the PGT testing, could we get some result and figure this out without having to actually do an embryo biopsy? So maybe the better graded embryo is going to be the more likely to be normal embryo, and therefore it's more likely to work. Well, as it turns out, that's not the case. It doesn't work out that way. Your best graded embryo may have complex chromosomal abnormalities if you do PGT with it, whereas your poorest graded embryo may be the only one in your batch that's normal. So I don't recommend that people get too held up in embryo grading, because it just doesn't really correlate so much with the outcomes. So now, when it comes time to pick an embryo, we got to have some criteria. So usually if we ask the embryologist, well, which embryo should we use? They will generally tell you, well, just pick the best looking one. And that's really what the embryo grade is. It is a beauty contest. So in the strictest sense of a beauty contest, well, some of them look better in a swimsuit. Some of them play the piano better. This one answers a question better. If it's really just a beauty competition, then they're going to pick the one that's the prettiest. But that's the only thing that it would have going for it, because you got to pick someplace. You could go the other direction too. You could say start with the lowest graded and work your way up. But so that's kind of the way that works there. And that looks like that came from Licio, I believe. Licio is something George, I think that says. And sorry for not being able to read the writing there. Kaylor, Alicia is coming on Monday for a transfer. Looking forward to seeing you there. Hey to Chef Blackney, good to see you around here this fine afternoon. And let's see, what happens if you miss one day of stim meds? That comes from Shida. Well, if you don't, what happens if you miss a day? Well, you may miss out on some growth that happens from the stimulation. So if you don't feed them, they will not grow. If you miss that initial day of stimulation and it's early on, well, your follicles may grow on their own or they may not grow very much at all. The right answer is don't miss a day of your stim meds. Now, sometimes later on in the cycle, we may see that you are a little overstimulated or hyperstimulated. And in that situation, we may say, well, let's coast you, which means just sort of take a day off, coast along. The follicles will still grow because they have momentum at that point, but it may keep them from overgrowing, if that makes sense to you. Let's see if we have some questions here on my Instagram. A special hello also to Mom and Dad in Mobile, Alabama. Let's see. This one says, hello, Dr. Fink. I'm so happy I started thyroid medication as per your instructions, and I skipped my cycle for 2 months straight. Had it this month, and I'm so happy. Well, okay, good deal. Thyroid is one of those things that we're trying to get your TSH to be between a particular range that is optimized for fertility. We're looking for that TSH number to be between a 0.5 and a 2.5. So many people will have a number that's a little bit outside of that range, and we suggest that you go on thyroid medicine. Well, it's not because your thyroid is sick. It's not because you've got a medical problem, but just we know that the thyroid hormone is optimized for fertility when it falls between that range, 0.5 to 2.5. Let's see what else we got going on here. A bunch of welcome back. Yeah, I can see the pink and orange. I'm not the orange guy. That guy's running for president, right? Crystal, glad to see you today. Thank you so much, my friend. Jordan gave birth to my CNY Colorado baby just last week. That is fantastic. Jordan, please send me by Instagram a picture of your baby so that I can post it for everybody to see. Alyssa Marie says, thoughts on immunoglobulin IV, that's IVIG, for failed implantations due to endometriosis or hypothyroidism. And I see a question below that. K Royale says, does CNY have a donor egg bank? Yes, absolutely we do. Okay, so Alyssa Marie, IVIG or IV immunoglobulin is usually something that we use for people who have specific types of autoimmune problems, or sometimes autoimmune problems that aren't specific types. They're things that we can't otherwise identify. So it's the biggest gun when it comes to treating immune situations. Recurrent failed implantations, the first thing I would think of is Prograf or tacrolimus, because there's very good evidence that tacrolimus is the treatment of choice for people with recurrent implantation failure. Now, if it's due to endometriosis, then 100% I would rather you treat the endometriosis, and that's with the either Lupron or Orilissa or the other medications called Myfembree, because that we know has a very direct effect on the endometrium, and that's that BCL6 marker. So IVIG won't really do the same thing. It suppresses an immune response, but it's not treating the BCL6 that's caused by the endometriosis. And if it's hypothyroidism, 100%, I would want you to treat the hypothyroidism, not so much use the IV immunoglobulin, which is incredibly expensive. So, if there was a practice I used to know of that would treat really everybody with IVIG. They really wanted everybody to be using IVIG. And they had very good pregnancy rates, but it excluded a lot of people because IVIG is outrageously, it's enormously expensive. So, if it were free and it were, we could pour it out of the faucet, I would say absolutely, sure, there's no reason not to be on it. But it's really not, in these situations that you're describing with endometriosis, hypothyroidism, and specifically failed implantations, I would say that we probably have some better treatment options. Let's see, how long should I take Omnitrope prior to a retrieval? This comes from Shine. Hi, Shine. I would say, again, the Omnitrope thing, Omnitrope is human growth hormone. All right. And it's relatively controversial because there are some studies that say it doesn't do anything at all to improve pregnancy rates. And there are other studies that say it makes a difference. In my experience, I think it makes a difference, particularly for folks who have had an issue with egg quality. How long to take it? Well, we don't really know that for sure, but I would say, and there are some programs that will just use the Omnitrope or growth hormone medication only during the stimulation. I kind of feel like being on it for a month before starting the stimulation is a good thing. I think 2 months, hard to say. It may be a better thing. But once you've been on it for more than about 3 months, in my opinion, at least based on some of the things that I've read, you may start to get diminishing returns. You may kind of max out your effect at that point. And so I'd say, a month is, or even 6 weeks is probably the sweet spot before starting your stimulation. Maggie Cox says, first medicated failed FET euploid hatching 3AA after laparoscopy and 2 months suppression. Would you suggest a modified natural next? I added on all the immune meds, Neupogen, lipids, prednisone. So you had a laparoscopy for endometriosis and you did 2 months of suppression. You transferred a single euploid embryo that was also highly graded, and you didn't get pregnant. So that euploid embryo had a 65% chance. It's not 100%. So I think that's okay. People can have a euploid and not get pregnant with it. By the time that there's 2 euploids, you're at an 88% probability of pregnancy. So I think the immune stuff is okay there. I love the modified natural FET. And so, yeah, Maggie, I would say I think that that's a really good plan. With the medicated cycle, we're taking away all the variability, but we're doing it, and this is the way they've done it in IVF, for 40 years with a medicated cycle. We're taking away the possibility of your body trying to do its own thing. Well, your body does its own thing every month anyway. It does. You make your own hormones. Those hormones do what they're supposed to do. They thicken up your lining. You ovulate. You make your own progesterone. So I feel like that's a good thing, and I would rather see you do that. Some studies show it has the modified natural or even a natural cycle has a little higher pregnancy rate, has a little lower miscarriage rate, and we know that it decreases the risk for blood pressure type complications that happen later on in the pregnancy. So yeah, I would do modified natural. I think that would be a great idea. Hello to Staley in South Florida. We appreciate you all the time. Staley is an old friend who worked in my office for many, many moons. And it's good to see you as always. Why is letrozole, Just Fame Music is asking, why is letrozole taken with Orilissa? I was never prescribed letrozole, but see it a lot prior to transfer. So it's not something I personally usually do. There are some providers who do. So when you take Orilissa for endometriosis, what you're doing, or for that matter, when you use a Lupron shot for endometriosis, what you're doing is that you're telling the brain to tell the ovaries to quit making estrogen. And that's really what it does. The problem is that we still get estrogen from other places. And in the case of letrozole, what it's doing is that it's telling your body. So we all have testosterone in the body. Men and women both have testosterone. And the more fat cells we have in our body, the more our estrogen or our testosterone is converted into estrogen. And that's through a process that's called aromatization. So what letrozole does is that it's called an aromatase inhibitor. It stops that conversion of testosterone to estrogen. But that conversion is happening out here in our fat cells, as opposed to the estrogen that the brain is telling the ovaries to make. So Orilissa is telling the ovaries, quit making estrogen, but letrozole is telling the fat cells to quit making estrogen. And that's kind of how that happens there. Do you recommend doing a laparoscopic surgery after an egg retrieval or before? I have mine scheduled in October already. So I do not recommend a laparoscopy solely for fertility purposes. And that goes along with the evidence-based approach and the ASRM, the American Society for Reproductive Medicine guidelines. Don't do a laparoscopy just for fertility reasons or just to diagnostic fertility reasons. Now, if you've got significant pelvic pain that suggests endometriosis, you may get some big benefit out of doing that laparoscopy. You may, ultimately feel an awful lot better. So that's okay. But I don't like people to delay their egg retrievals. The sooner you can get to that egg retrieval, the better off you're going to be, because the sooner we get the eggs from you, the greater the probability that those eggs will be normal. The younger you are when the eggs come out, the better the chance that those eggs will be normal. Let's say hi over here to all our friends on Facebook. Let's say we've got Facebook and we've got YouTube and we've got LinkedIn right here on the middle camera. And finally, people came in to say hello. Hello to Nicole. You are number one over here on the Facebook side. Alicia, Dineo, I think. Doctor, do you speak Spanish? Unfortunately, no, I don't. Alicia Lampert says, I'll see you Monday for my transfer. Here's a question. This transfer is the first time with a higher dose of tacrolimus. Little worried about the higher dose with the immune system. Should it even be a worry? The dose that's recommended there is 3 milligrams. So you can take that 1.5 milligrams twice a day, or you can take that 1 milligram 3 times a day. That is the recommended dose to prevent the body from reacting against a transfer as though it was a foreign body. There should be no danger associated with that. It's a very strong evidence-based approach. So we used to use 0.5 milligrams twice a day. And because it seemed like a good idea, and there was some evidence that supported it, and that there's some group of people in whom that would be a benefit. Well, but then the study came out in March that looked at people with recurrent implantation failure, and they looked at a variety of different doses using the tacrolimus to determine, what's the best dose. At that 1 milligram a day dose, it really didn't do very much. At 2 milligrams a day, it did a little bit more, but still not very much. At 3 milligrams a day and above, it made a very significant difference. So that's where the number comes from. So I think you can feel pretty comfortable with that. Alicia, Colleen says, I have a very few euploids, so want advice about proactive immune testing ahead of transfer that I can do beforehand. Can CNY do blood work to try to figure out whether prednisone, Lovenox, Neupogen, Plaquenil will benefit me or not? Do you recommend Pregmune? I've only had one failed day 3 transfer, but I do have an autoimmune disease that I take Humira for. So I don't want to oversuppress my immune system, but want the add-ons if they make sense. Well, really, if you want to do that, what you're talking about is kind of having a consultation with a reproductive immunologist. So our thoughts are that there is a segment of the population for whom one or more of these things will be beneficial. And so therefore we recommend using them. That's why, especially if you've got some autoimmune problem, that we know that you've got inflammation going on in your system. And inflammation stands in the way of people getting pregnant. The big question there is, well, all right, do I need it all? Well, it's really hard to say. There is not a specific group of tests that we will order for you pertaining to those things. The Pregmune test is basically like an AI version of a reproductive immunologist. So you Pregmune, you subscribe to the test, and that's Pregmune. And they have a nice website. You can take a look at the website. You pay for the test, They order your blood tests, which you can get from Quest or LabCorp, any general reference lab. You do that, and then it runs it through these results all through its proprietary algorithm, and it produces like a 65-page report that really goes over everything, of the results of these things and what it's testing and why it's testing. And it is a very comprehensive set of autoimmune tests that are specifically related to fertility, and it interprets them for you. It really goes beyond what we do in general, IVF or infertility, to try to interpret all those things for you. So I would say if that's something that you're interested in, Pregmune would probably be a good choice for you. Um, Ashlyn says 8 weeks with my day 3 fair graded embryo. God, I love to hear that. So that was an embryo that said, it's fair. And you would say, oh, well, I kind of was hoping for something more than fair. Well, guess what? You got something, Ashlyn. You got something a lot more than fair. You got a little baby bump that's going to be starting to grow any old time now. I am so happy to hear that. Thank you for sharing. Erica Conway says, oh, congrats, Ashlyn. Yeah, that's awesome. Thanks, Erica. Victoria says, I'm 24 and I've been diagnosed with lupus. What should I do before a transfer? Well, so first of all, you want to make sure that your lupus is optimized, that your rheumatologist and an OB has given you clearance to go ahead with the pregnancy. Lupus is a disease that can be very dangerous in pregnancy, and so we want to be very careful with it. Strictly speaking, from an embryo transfer perspective, it's fine to do. We would certainly want you on one of the probably immune protocol, at least level 3, taking some Plaquenil beforehand, and then some Prograf, switching over at the time of about the middle of that cycle. But I would really encourage you to visit with your immunologist, or your rheumatologist, and also your OBGYN, just to make sure that they're all on the same page with you there as it comes to getting pregnant. Liliana says, after a failed transfer, how soon can you do an egg retrieval? The very next cycle. So you can go right into that the next cycle, Liliana. No reason that you have to wait. Kelsha says, hello to my favorite doctor. Oh, did you hear that? Wait, tell me, who is your favorite doctor? Tell me who it is. I'll find out. I'll tell him hello for you. Okay, I recently had, thank you for saying that. You made my day there. Recently had a hysteroscopy done because during a biopsy for abnormal bleeding, it came back positive for a polyp. How do I know if they got it all out and implantation will be successful? I already have older children naturally, but because of my age, I'll be using a donor who'll be cycling next month. Okay, well, so what do you got to know there? So you had a polyp removed, and that's a good thing. We generally recommend that you evaluate your uterine cavity once per year. And that's either with a hysteroscopy, or you can do a saline sonogram, which is where you place a little straw inside the cervix, place a teaspoon of fluid inside while doing a vaginal ultrasound to show that that polyp is gone. Well, if you had a polypectomy, to ectomize is to remove a polyp. They placed a camera inside in order to be able to see it. And because that whole thing was done under direct visualization, you should assume that the entire polyp has been removed. So you ought to be in good shape, and we will all keep our fingers crossed for you with your donor. By all means, that is awesome. Okay. Kelsha also says, I have a high BMI. Should I lose weight before transfer? Does weight really affect implantation? I never had high blood pressure or any other health issues. Well, we do know that in women with a BMI of greater than 35, there is a lower pregnancy rate even using euploid embryos. There is some evidence to show that losing weight can be helpful for improving pregnancy outcomes, but you have to balance that against, well, okay, so how much time are we talking? And certainly we know that the GLP-1 agonists, things like Ozempic and Zepbound and Mounjaro, these probably do improve fertility. How do they do that? Well, it has a lot to do with with kind of things really mostly related to hormones, but I'm sure that you've read many of the same articles that I have that talk about, people having Ozempic babies because they lost some weight and suddenly they got pregnant when they couldn't have gotten pregnant before. The other consideration there, Kelsha, is that I would want you to be as well tuned up as you can be before you get pregnant, and that goes across the spectrum as far as health goes. You gain weight with pregnancy, you have a baby, and it's really hard to lose that weight after pregnancy. So I'd say the more teed up you can be before you get pregnant, the better off your outcomes are likely to be. Hey, by the way, it's 31 minutes past the hour, and this is Fertility with Fink and Friends. I am Fink. You are Friends, and we are live as we are every Tuesday evening between 4 and 5 Mountain Time, or 6 and 7 o'clock on the East Coast, 3 to 4 for those on the West Coast. And I am here in Colorado Springs at CNY Fertility, and love the opportunity to be here with you, and certainly appreciate you spending a little bit of your precious time with us. Okay, let's see what else we go. Hello from Queens. Sabine, thank you for sending your greetings, and hi to Monique. Sama says transfer of 2 embryos at the same time, pros and cons for a 42-year-old woman. Well, so it depends. It depends on what you mean by that. It depends on what kind of embryos really that you have there, because you can transfer at 42. You would be within the guidelines to transfer multiple embryos, and that may improve your pregnancy rate, because we know that the odds that all the embryos are going to stick when they're made from 42-year-old eggs, the odds that they're going to stick is not high, that they would all be normal. So therefore, you can transfer more than one embryo without having to be overly concerned about the risk of multiples. So generally speaking, I would say it's probably okay, unless we're talking about tested or euploid embryos. And in that scenario, 100%, I would say you want to transfer one embryo. Hello to Erica Walden, and oh my Glenda, we're going to Colorado location, but I'm from Las Vegas. We have a different doctor for consultation because you're booked until the end of October. Gosh, I didn't know, but we can't wait to start this IVF journey. And I can't wait to see. We love the folks from Las Vegas. Everybody from Vegas is always very, very nice. So, Glenda, we're so happy to have you involved. There was a question I saw over here that caught my eye. Monique is asking about, what department do I message once the office is closed for Colorado? I'm reading the pamphlet, but all it says to contact via portal. So if you are outside of one of our local facilities, so let's say you live in Colorado Springs, then you would message Colorado Springs Nursing. But let's say you're planning to come to Colorado, however you live in, say Oregon, you would message our global travel nursing team, or the global team. They're the folks who will read all those correspondences, and they will get back to you tomorrow. Nurtured Shanna says, should be having an egg retrieval in the next few days. Can you talk about ideal abstinence date range for giving sperm to improve the quality? So generally we say about 3 days. So let's talk a little bit about sperm, since we're all in the mood to talk about. Hey, I'm back from vacation, so we can talk about sperm. I'm not really sure that made any sense, but okay. So the eggs in the ovaries, as you know, have been with you since before you were born. They were developed when you were in utero. The sperm that comes out today was manufactured in the body about 3 months ago. When sperm has a chance to hang out in the body, and it's usually stored in a structure that's called the seminal vesicles, which sort of sit next to the prostate and under the bladder. they can start to, kind of break down a little bit. They start to get a little wonky, is the word I've heard used. They develop some defects in the heads and in the necks and in the tails. They can start to swim funny. The motility can decrease, and the number of live sperm, the sperm can start to die off and still just sort of be collected and hang out there waiting for expulsion or ejaculation. Well, so the ideal amount of time in most men is about 3 days, because once you're beyond about 5 days, you start to see some defects in the sperm. 3 days is generally considered to be, kind of the sweet spot for sperm quality. Now, there's a caveat to that, and that is that some men have an issue with what's known as DNA fragmentation or sperm fragmentation. And what is a sperm anyway? Well, it's a little packet of DNA, a packet of genetic material with a motor on it, right? The motor propels it around. And again, if you didn't catch that little visual for you, a little sperm swimming by there. Thank you. Thank you. Boy, that derailed my train of thought in a hurry, didn't it? So sperm is a sort of a packet of DNA that swims around. If that DNA has started to break down or become fragmented, it's starting to kind of come apart, that may not affect the indices that we look at when we see the sperm. So you may be able to do a semen analysis and see an absolutely normal sperm count, and see motility be excellent, and see that the morphology looks really good, but there's a problem with the DNA in those sperm that you can't tell from looking. So the frequency of ejaculation can also decrease the amount of DNA fragmentation that's happening. So normally we say 3 days, but in a couple where we've seen there may be some issue with the sperm, then I usually suggest, okay, I'd like you to ejaculate every single day leading up to that collection, because our sperm count will go down, because with each successive ejaculation, I think we lost a little video there. With each successive ejaculation, we will decrease the sperm count, but we will improve the sperm quality. All right. Quantity may go down, but quality goes up. And when we're doing things like IVF, the quantity may not really matter so much, because if your normal sperm count is, call it 25 million, and you ejaculate more frequently and it drops your sperm count to 15 million. Wow, it's a 10 million decrease in the sperm count. But at the end of the day, how many sperm do we need for each egg? One. We only need one sperm. So if there's 15 million instead of 25 million, does that really make a difference? No, probably not. This reminds me of so hopefully that answers your question there, Shanna. This does remind me of a conversation that I had today with a patient who asked me a question about an AMH. She has a relatively high AMH, and in her retrieval, she produced a lot of eggs. And those two things kind of generally go hand in hand. If you've got a high AMH, it means that you're probably going to respond very well to the medication and make a lot of eggs. And quantity is not the same as quality. So I tend to want to dial it down. And in her situation, we did just that. We dialed down her dosage, but she still made just a lot of eggs. I think she had something like 65 eggs or so. And so her question to me was, well, does that mean, because I had this procedure done where I had so many eggs removed, or because I had IVF where I had, multiple eggs removed, because I normally ovulate one egg a month, since I had multiple eggs removed, does that mean I'm going to go through menopause sooner? And I think that that's a very fair question, but the answer is no. So, first of all, the AMH level tells us really it's your ovarian reserve, the anti-Mullerian hormone, and it tells us how really you're going to respond to the IVF medication. It doesn't tell us anything at all about your ability to conceive spontaneously or when you might or might not go through menopause. It is absolutely not a marker for that intention. And she said, but I don't understand because, normally I release one egg and you just took out 60. Does that mean that I'm now 60 months sooner to end up in menopause? And the answer to that is no, because by the age of 35, we're actually losing about 10,000 eggs a month just from aging alone, because these are, you think about them, these eggs, they're not like, eggs in a carton that you buy from the grocery, but rather they're just single cells, invisible to the naked eye, that are just hanging out, sitting in the ovaries. And 10,000 a month is what we're going to lose by age 35, just based on those cells kind of dying off. So if we stimulated those ovaries and we got 65 eggs, well, that's still kind of just a rounding error. It's a tiny fraction of the 10,000 eggs a month we would otherwise use based on aging. So that's why it doesn't have any effect on making menopause sooner. And when you think about, gosh, 10,000 eggs a month, it makes you think, I wish I had saved some eggs when I was a little younger. And that's why I'm a big proponent of egg freezing, because egg freezing gives you options later on down the road you may not need. It's a fertility insurance policy. You can still get pregnant in the normal way. You don't ever have to use these eggs, but it sure is nice to have them around just in case you need them. So let's see what we got going on over here. Will IVF work if having premature ovarian failure? So, generally speaking, the answer is unfortunately no. Premature ovarian insufficiency or ovarian failure happens when the ovaries prematurely, which is said to be before the age of 35, run out of eggs. And in that scenario, it results in an early menopause. Recommendation is that you're on some hormone therapy to keep you young and to keep you healthy and to be very protective on your heart and your brain and all the other parts of the body there. So IVF can be very successful when we're talking about using a donor egg in that scenario. But the very definition of the premature ovarian failure is likely that there are no more eggs that are left in the ovary. So the process of trying to retrieve an egg, I personally have never seen successful. Now, there may be some variance there. Folks who have are not completely without eggs may be partially or in intermittent ovarian insufficiency. They can sort of flip in and out of it. So there may be a scenario. I never ever ever say never. But donor egg would give you a very, very high probability of getting pregnant, whereas trying to use your own egg would unfortunately give a very low probability. Let's see. Orion LS says, is Gonal F 450 units a day high for IVF with stage 3 endometriosis and with one possibly blocked tube? Well, so the dose that we would use of stimulation medications for IVF is not really based on whether you have endometriosis. It is generally based, 450 is a reasonably high dose of gonadotropin, of that type of medication. But the dosing is generally based on age, and secondarily on the AMH. So I would say it kind of depends on where you are in that situation. But Ryan, 450 is a higher dose. But endometriosis wouldn't be the reason that we would go there. Giovanna asked, well, then who would be a good candidate for mini dose IVF? So mini dose IVF just means kind of it's a low dose therapy. And and we use that in two different ways. So if you're in your 20s, then I'm going to say a mini dose is going to be the standard dose that's appropriate for you. If you're in your 30s and or 40s and you have polycystic ovaries, then a mini dose may be a better idea than an age appropriate dose so that you don't hyper stimulate yourself. In folks who have, the other place that we here at CNY feel very good about using mini dose therapy is in folks who have a lower ovarian reserve. So in that scenario, the older wisdom was that we want to give you as much medication as we can to try to get your ovaries to respond. So if you have a low AMH, we're going to dump as much medication as we get on those ovaries so we can try to squeeze an egg out of you. However, what happens is that the ovaries don't really know what to do with all that stimulation. So as a result, they may not do much of anything. They may just kind of stop responding. You may use a very high dose. I've seen situations where people spend $10,000 and $12,000 on medications, which is it's mind-boggling when you think about it there. So using the high dose isn't going to get you the response. What the data from Europe shows us, and in Europe, the governments cover the IVF in most cases, but the government tells you what kind of dose of medication you're going to use. And they don't care if you get 20 eggs or you get one egg. They're paying for it. And so they're going to tell you what dose you use. And they use very low doses for everyone. So what we've been able to glean from that is that, okay, we know that the very high dose therapy may not get you a response. But what we've learned is that using a low dose therapy, or what we call a mini dose stimulation with a low AMH, typically gets you the same kind of outcome as you would expect from using the high dose therapy. So you may have fewer follicles, but in terms of the number of eggs, the number of embryos you produce, you're likely to get pretty close to the same kind of outcome using a mini dose therapy as you would with a very high dose, but at a significantly lower cost and at a much lower side effect profile. So that's really why we use mini dose. And hopefully that answers your question there, Giovanna. Thanks for being here on this Tuesday. Chef Blackney says, hello, Chef. I will be starting stims with you next month. Will you recommend mini or regular stim with an AMH of 0.825? So 0.8 is less than a 1, and so that's generally considered diminished ovarian reserve. And that may be one situation where a mini dose therapy could be useful. Now, Chef, I don't know how old you are, but let's say that you're in your mid-30s. I might also say, well, before dropping to a mini dose, it may be that an age-appropriate dose would be the right thing for you. So not a high dose over here, but not a mini dose over here. The age appropriate dose would kind of just be right there in the middle. And so sometimes we might go there as well. And my hope is that you are going to score. What size of a follicle is considered as too big or over mature? Well, when things get above about 23, 24 millimeters, they probably are not going to produce usable eggs. In fact, in many cases, those are what we call anovulatory follicles. They basically, it's a follicle that's been created without an egg, or what we also sometimes call a cyst. Let's see. Do I think Oralissa can successfully shut down endo even stage 3 or 4 for successful FET, or should I just go for surgery? I would just use Oralissa. Now, because I think you mentioned that was from Rosa, that you really don't have any other symptoms. So to be honest with you, all you really want is to shut down that BCL6 in your endometrium. And I think, that's what you're after. And I think you will achieve that with the Oralissa alone. We got 10 minutes left until the top of the hour at Fink and Friends, live from Colorado Springs. Let's see if we can get to some more questions here. I'm going to flip back over to my friends on the Facebook and YouTube, LinkedIn side. Marcia says, I'm curious at how does ovasitol, myoinositol, dechiroinositol work in the body? It's a complicated question there, Marcia, but it has to do with treating insulin resistance. And we all have some degree of insulin resistance, and this insulin resistance can result in a situation where the estrogen environment at the level of the egg is such that it starts to diminish the egg quality. So we add things like metformin, or in the case that you're asking about is inositol or myoinositol, in order to try to treat that to improve egg quality. Now, specifically, I recommend plain old myoinositol. There is something that's called dechiroinositol, and you asked about that. That actually harms egg quality, but there is a supplement out there that has a ratio of the dechiroinositol to myoinositol of 40-1, happens to be the ratio. There's much more evidence on myoinositol alone, and so that's, personally speaking, what I would recommend. So it works at the level of the egg in terms of insulin resistance. Even if you have no other markers of insulin resistance, my feeling is that if your AMH is above a 3 or below a 1, then I either want to see you on metformin or inositol. And inositol is just another way to kind of do it without the medication. So that's my 2 cents worth. Now, please don't radio in and say, but my AMH was 3.1 and nobody started me on metformin. It's not a must. These are all just, everybody has different opinions. You will be hard pressed to find any 2 doctors who will agree that the sky is blue outside. So we all have different opinions, different little ways that we do these things. And so have trust in the system. Anna Williams says, is traditional IVF more successful than mini IVF? Well, it really depends on your what that AMH is and what we're actually treating there. So mini IVF is no different than regular old IVF. It's just using a lower dose of medication. As we talked about there. Tasha says, is letrozole necessary if you're already stimming with Minipure and Follistim? So letrozole does a couple of different things for you. It may help to recruit eggs through a different pathway. And we have found that in women who are generally over about 35, that can improve the pregnancy outcomes. And letrozole also decreases the estrogen level, the estradiol level, when we check that in your blood, which may be beneficial in some circumstances for egg quality. So that's generally why it's used. The Follistim and the Minipure, these are other medications that are telling the brain how to tell the ovaries to produce eggs. And ultimately, that is our goal. Let's see. Alexa says, do you continue to Prograf once the pregnancy is confirmed? Yes, I recommend. My recommendation is that you stay on Prograf through the first trimester. Why is that? Because there are many of us who believe that recurrent pregnancy loss is a very close relative to recurrent implantation failure. And so we can also treat recurrent pregnancy loss with the use of tacrolimus or Prograf. And since most pregnancy losses happen during the first trimester, staying on the medication through the first trimester is my recommendation. Now, there are some situations where folks have had poor pregnancy outcomes, even later on in pregnancy. So there is not a reason in that scenario that you can't stay on it, even longer. But it's a very individualized thing by the time we reach that point. Michelle says, my consultation at the end of September, currently on Ozempic, and I'm down 35 pounds since April. That's awesome. Awesome, Michelle. That's great. When do I have to stop the shots before scheduling a transfer? Someone who's diabetic and high risk is more than one embryo transfer possible the first time. In that scenario, we probably wouldn't recommend multiple embryo transfers, Michelle. We would still really go by the guidance from the American Society for Reproductive Medicine. And you can look that up online, ASRM, embryo transfer guidelines. And that will tell you really it's based on age. Now you've got some other comorbid factors there, such as the diabetes, and yep, that does increase your risk as well. So we really, really want you having a single pregnancy, one baby at a time, one healthy baby at a time. We really don't want you having multiples if it's avoidable. Now, currently the recommendation for semaglutide or Ozempic is that you're off that medication for 2 months prior to conceiving. Where did that number come from? It seems a little arbitrary, some people say, and I would say you may be right. It is a little arbitrary, but it's based on what's known as the half-life of the medication. The medication stays in your body for a while, even if you're not using it on an ongoing basis. And because it wasn't studied in pregnancy, the FDA says it's not recommended in pregnancy. So therefore, we think you ought to be off of it. Now, do you think that's going to be the case forever? In my opinion, I bet you at some point they're going to change that, because there's going to be enough of a database of people who conceived on semaglutide or Ozempic that they can collect data to show it about the safety on pregnancies. We also suggest that if you're having a minor surgery or something like an egg retrieval, you can be on Ozempic for an egg retrieval, but let's say you're going to the hospital and you're going to have a hysteroscopy or a diagnostic laparoscopy, take a look at your fallopian tube. They want you to skip the dose the week before and the week of. And if you'll do that, then anesthesia is considered safe for you under that scenario. Jessica says, just started the IVF process. If I transfer 2 embryos, is there a possibility of both splitting to create 4 babies? And the answer is yes. 2 can become 4 and 4 can become 8. And yes, I have seen it happen. Absolutely. Michelle Stewart told me, I thought that said Martha Stewart. Martha Stewart does not work here. Michelle Stewart said they told me 2 months before I was on it, and also diabetic. Yeah, 2 months to stop Ozempic before doing a transfer. You don't have to stop at 2 months before doing a retrieval, however. All right, we got a few more minutes here. Ashana says, just had a failed FET, having an endometrial polyp and a tube removed next month. When can I transfer again? So once you are done with your surgery and you have recovered, you can go right back into really that next cycle. It should be fine, Ashana. A special hi to Alexis Laurenti in Miami, a wonderful nurse practitioner there at the Miami Center of Excellence. Let's see what else we have going on here. It looks like Noir Lux Cosmetics. What would you suggest for 26-year-old female, 1 chemical pregnancy and 1 blighted ovum? Should I transfer 2 4AA embryos next? Those are both good quality embryos in somebody who is 26, who has a really pretty high probability of having a chromosomally normal embryo. I would be thinking after a blighted ovum and after a chemical pregnancy that this may be an autoimmune type issue. So I would have you on Prograf, 3 milligrams, 1.5 twice a day, or 1 milligram 3 times a day, and I would transfer 1 embryo in that scenario. Because transferring multiple embryos may increase the probability of you getting a positive pregnancy test, but at 26, it increases the risk for pregnancy loss because multiples is associated with not such good things happening, not such good outcomes. So that's why we think so. Shabnam says, I'm 8 weeks pregnant. Are you? That's awesome. With a not PGT tested embryos, it's still possible to have a miscarriage because the embryo is abnormal. Yes, miscarriage, again, is most common in the first trimester, so up through 12 weeks. But once we look at an ultrasound and we see a heartbeat there, Shabnam, we know that 95% of those pregnancies will continue on without having a problem. So the best odds you could ask for, simply seeing the heartbeat. And God bless. I am so happy after seeing you on here for such a long time that you are now 8 weeks pregnant. And that is really fantastic news. It's top of the hour, which means it's time for us to wrap up this week. We will be back next week at Fertility with Fink and Friends. My name is Dr. Randy Fink from CNY Fertility in Colorado. We would love to help you bring your family dreams to reality. Like I always say, and on the sign behind me, which is backwards, I think, but I want you to know every day should be a new day of kindness, random acts of kindness towards other people. Keep this world turning in the direction it needs to go. Every day forward with love and hope, knowing that the sun rises tomorrow and it's a new day, and all that, if you don't mind my saying, all that shit that happened yesterday is really just a memory from yesterday. What we have is tomorrow. This is not the book of your life. This is just one chapter. And what are we doing? We're here to rewrite it together. So until next week, thanks again for being here. Dr. Randy Fink saying good night.